Me a second while give me a second while I pull up the presentation. Okay, does everybody see my slides okay?
Yes.
Okay. And the um the people on the call, they're primarily NICU, all NICU RNs or SBU or both.
Looks like a mix of both, primarily nurses, and then we have Dr. Raker and Dr. Tran.
Okay. So I actually just gave this brief talk. It's a little bit different than what I typically do, which is more like practical information for our nursing staff to use and residents to use in the management of patients with neonatal neurologic disease. I wanted to just talk about some of the research that myself and some of my colleagues are doing that will hopefully push the field forward. So my research project is titled, and Brenda, I'm sorry that you're hearing this again. But my research project is titled Using Neonatal EEG to Help Determine the Risk of Epilepsy. And the goal of the project is to identify EEG features that are significantly associated with increasing your likelihood of going on to develop epilepsy, but also using neonatal EEG features that are significantly associated with a decreased risk of developing epilepsy. So I just wanted to define a few terms first and talk about why this is so important. So the majority of times when neurology is consulted for a neonate with seizures, they're either going to fall into one of two categories. The first is what we're most used to, and that is patients with acute symptomatic seizures. So these are seizures that are happening within the first 30 days of life that we attribute to some cerebral insult, be it hypoxic ischemic encephalopathy, intracranial hemorrhage, CNS infection, electrolyte disturbances, hypoglycemia, um, sepsis. Um, and in our minds, we are thinking, all right, well, once we're past this phase, we shouldn't be at high risk of having seizures going on into the future. Um, Contrast that with the other group of neonates that have seizures, and that is the population that we better characterize as neonatal onset epilepsy. So when we say epilepsy, we're talking about an enduring predisposition for seizures on into childhood. So seizures that happen in the neonatal period, but then at discharge we might be saying, okay, we need to leave this child on anti-seizure medicines because we think they're going to have seizures on through the rest of their life. So these are our rare conditions, our brain malformations, our metabolic diseases, genetic conditions. And so I don't want you to be thinking about this patient population. Again, it represents a small fraction of patients that we see in our NICU. We're going to be entirely focused on the first category, and that's the neonates that have acute symptomatic seizures. So why are we talking about this? At the heart of it, one of the most controversial questions that's been asked within neonatal neurology is how long do you keep anti-seizure medicines on for neonates that have had seizures? And I remember as a resident, early 2000, early 2010, 11, as a resident, I just remember seeing patients who were on phenobarbital that were in their teens and just thinking to myself, did they really need to be on this medicine since birth? What happened? And then you go back and you look, okay, no, they had HIE, they had cooling, but nobody ever thought to stop the medicine. So neurology, pediatricians, in subsequent follow-ups just kept weight adjusting for the phenobarbital. And so obviously that carries with it a high degree of dysfunction being on a barbiturate for that long. And so that kind of got me curious. When is a good time to stop anti-seizure medicines? And so, right around that same time, the World Health Organization came out with the following statement, and that was in neonatal seizures, consider stopping anti-seizure medications 72 hours after last seizure if exam or EEG is normal. When is our EEG ever normal? We're on sedation. So, anyways, the this wasn't that convincing a recommendation, and maybe it was just where I trained and where I continued to train, but I never got the sense that in the early 2000s and teens, people were getting patients who were having seizures off of anti-seizure medicines prior to discharge. And again, maybe it was just where I trained, but it wasn't something that was readily done. It seemed the practice was more, well, let's discharge them on anti-seizure medicines and let the neurologist figure out what to do once they're seen in clinic. So, anyways, it wasn't until 2022 did we first get very strong guidance on what to do with anti-seizure medicines. And that was from the International League Against Epilepsy Task Force on Neonatal Seizures. They put out the following statement, and that is following cessation of acute symptomatic seizures without evidence of neonatal onset epilepsy, anti-seizure medicine should be discontinued prior to discharge home from the hospital, regardless of what the MRI brain and the EEG shows. So, like, the pendulum is swung all the way to the other side. We need to be discontinuing anti-seizure medicines on all of our babies that had acute symptomatic seizures, no matter what. And I remember that was nice. Okay, at least we're moving in the right direction, but are we moving too far? What about our kids who have severe HIE or severe intracranial hemorrhage? Should we be coming off of anti-seizure medicines before discharge? I know my practice has always been I'll give them like a 1 to 2 to 3 month period to demonstrate seizure freedom prior to coming off of anti-epileptics. But no, I spoke to the people who actually came up with the guidance, and it was very clear. You're taking them all off of anti-seizure medicines prior to discharge. And the thought behind that was there is no serious evidence that shows leaving these kids on anti-seizure medicine is going to prevent the development of epilepsy. And so if our choices are phenobarbital, you'd rather come off of the phenobarbital even if it means maybe being slightly higher risk of developing epilepsy. Anyways, so that's a little bit of the history behind it. Hannah Glass did a really nice study looking to answer this question very specifically is what is your risk of epilepsy in this patient population that have acute symptomatic seizures? And so her endpoint was no development of epilepsy by 24 months. She looked at all the patients who had acute symptomatic seizures, and overall of the 282 neonates that had acute symptomatic seizures, 13% went on to develop epilepsy or hard to control seizures later on in life. And 11% of those patients were off of anti-seizure medicines prior to discharge, whereas 14% were left on anti-seizure medicines after discharge. So that really served as the foundation, I think, for the recommendation is look, your risk for developing epilepsy after acute symptomatic seizures is low, regardless if you're on anti-seizure medicines or not. So why not just stop it? Which makes sense. And if you're wondering, well, that's strange. Why is it that more neonates are developing epilepsy? Um, the group that was kept on anti-seizure medicine, that's selection bias. I mean, the kids who are continued on anti-seizure medicines are the sickest of the sick. And so ultimately they're going to be at higher risk for having epilepsy. So there is one study that I just wanted to mention in here, which this was good. It was Carrasco and Bonifacio's study. really giving the clinician guidance. They're basically saying, look, here's here's here are the situations where you are reasonable to stop the phenobarbital. Here's the time frame where you should stop the phenobarbital, but we're going to leave it up to the discretion of the provider to determine whether or not you want to come off of it in those severe cases. So severe HIE, large ischemic strokes, large intracranial hemorrhage, they're saying, look, we think it's reasonable if you want to continue the anti-epileptics and not rock the boat and to consider transitioning those kids over to Keppra, which is what we've done. On some of our patients. So again, no evidence to believe leaving them on anti-seizure medicines lessens your risk for developing epilepsy. So, you know, everybody has their own practice. I think ours historically here has been to try to get neonates off of anti-seizure medicines prior to discharge, with the caveat that, it's a shared decision between families and the clinicians. We're very much wanting to meet the family where they are and discuss benefits versus risks, and then go from there. All right, so back to our study. So, um, when it comes to the study that we're doing, myself, Dr. Dan Schrei, who's one of the epileptologists, the question we're trying to answer is which neonates with acute symptomatic seizures go on to develop epilepsy? Like, what are we missing in terms of the past medical history or the procedures that we're doing? What biomarkers might help us predict who's going to develop epilepsy and who's not? Again, not to say that we need to keep those kids on anti-seizure medicines, but just to answer the question, who's high risk and who's not. So in order to do this, I needed a list of all MRNs that included the following criteria: born after 2010, 28 days or younger, completed one of the many anti-seizure medicines that we use in the NICU, and then had an ICD 10 diagnosis, including seizures or some word adjacent to seizures that could imply the patient had neonatal seizures. So with that, I got 503 MRNs. Since our inclusion criteria, we're only looking at kids who had EEG confirmed seizures. We whittled that down to 293. And what I'm going to be presenting is a fraction. What I'm going to be presenting on today is a fraction of that. So we're looking at 43 neonates with EEG confirmed seizures. Um, I then went through and saw which of those 43 were lost to follow-up, because if they were lost to follow-up, I'll never know whether or not they developed epilepsy or not. I'd like to think if they were lost to follow-up, they did good and they didn't need to see a neurologist, but no, for purposes of research, I couldn't include those. And so we whittled that down to 27. I also excluded patients where, in retrospect, they should have been classified as a neonatal onset epilepsy. And again, that's not the patient population that we're analyzing. So I had a lot of help from Dr. Schrei and Dr. Inder. They had created, as some of you are familiar with, a cooling database on REDCap, because they're doing their own studies with the HIE population. And so I wanted to collect basically all the same information they were collecting, but I needed additional seizure EEG relevant information. So I included, and I'm not going to go through it, but there are certain EEG features that we look for within EEGs that I wanted to include in the data capture: whether or not there were seizures, where the location of the seizures are, what anti-seizure medicines we gave them, were they discharged on anti-seizure medicine, what was the etiology. To answer that question, was it acute symptomatic seizure or postnatal epilepsy? And then, of course, the follow-up clinic visit to answer the question, did they develop epilepsy? So of the 27, 10 were HIE, standard cooling. Five were unfortunate cases where we either got them too late or didn't get cooled, but were found to have cerebral ischemia on MRI. Arterial ischemic strokes made up a good chunk of the subjects, and then hypocalcemia, CNS infection, hyponatremia, intracranial hemorrhage, intraparenchymal hemorrhage, and idiopathic rounds out the 27. Okay, so before I actually get into the analysis of the data, does anybody have any questions about any of that so far? Strengths, weaknesses, just the project setup, or just some clarification of what I mean when I say acute symptomatic seizure versus neonatal onset epilepsy. Okay, we'll move forward. Okay, so of the 27 patients that we were able to analyze, um, 22 of the 27 did not develop epilepsy. Now, the weakness here is that range of follow-up was anywhere between 4 months to 38 months. The majority of that 22 fell in after 2 years of age. So we got at least 2 years to say, okay, that patient hasn't developed epilepsy. But again, we had a 4 month old that was lost to follow up, a 8 month old, I think that was lost to follow up. That when we did see them at those time frames, they had not yet developed epilepsy. And probably when I do the final analysis, my outcome measure is going to be something along the lines of did not develop epilepsy by 1 or 2 years of age. And so, of the 5 patients that were diagnosed with epilepsy, um, 3 of those 5 developed infantile spasms, and I'm going to get into that here in just a bit. So, 18.5% of our patients with acute symptomatic seizures went on to develop epilepsy, and that number was 13% in Hannah Glass's study. All right, now we break it down to patients that we stopped anti-seizure medicines on prior to discharge against those that were continued. So, of those that we stopped anti-seizure medicines on prior to discharge, only one went on to develop epilepsy. And so that's 9%. So that's more in line with Dr. Glass's study, where I think she had said 11% of those patients that had ASMs discontinued prior to discharge went on to develop epilepsy. And I included this data as well. I think I need to change it, but I included average time to when we stopped the anti-seizure medicine, and that was at 12 days of life. I think the more relevant variable here would be time from last seizure to time we stopped anti-seizure medicine. Because I think if we can really clarify what that number is, let's just hypothetically say it was 5 days. Maybe we feel better about waiting 5 days prior to discontinuing anti-epileptics, or at least provide some guidance that it can be discontinued much earlier than before 12 days of life. So, anyways, that's data I have. I just haven't looked at it yet. So the other population of patients that were continued on anti-seizure medicines, 4 of those 16 went on to develop epilepsy. And that's 25%. So again, it's another situation where, why are the kids that are kept on anti-seizure medicines, why does it seem like they're more prone to develop epilepsy? It's because we're keeping kids who are more prone to develop epilepsy on anti-seizure medicines. All right. Now to get into the like really fine details. There are these markers that we assess on EEG. They're called negative sharp wave transients and brief rhythmic discharges. Question is, can we use either one of those to help us predict who's going to develop seizures or not? I think the short answer is no. Of the 4 that we analyzed that did go on to develop epilepsy, all all four had negative sharp transients, all 4 had brief rhythmic discharges. And of those that did not develop epilepsy, about half of that patient population had negative sharp wave transients or brief rhythmic discharges. So it's in no way predictive of the development of epilepsy. And no major um, I'm not, no, there's no recommendations or guidelines to be made from just this very small analysis. It's just hopefully we're just gaining some insight into the data and what these transient features could mean. And we're going to go on to look at other features of the EEG too and how it might correspond to whether or not one might develop epilepsy or not. So one particular variable that I was really interested in was time to first seizure after the VTM was connected. My hypothesis was if we're hooking a child up and we're immediately seeing seizures, this is not going to bode well for them long term. They're probably higher risk of developing epilepsy because they've probably been seizing for quite some time. Um, and so in that patient population that did go on to develop epilepsy, the average time to seizure after VTM was connected was 13.2 hours, whereas the first time to seizure after VTM was connected in those that did not develop epilepsy was 4.2 hours. I do need to say that there was one major outlier in the developed epilepsy category. We had one particular patient that had 55 hours of no seizures before generating that first seizure. And that 55 hours was characterized by a very abnormal pattern where there is a lack of differentiation on EEG and just extremely suppressed, um, which in and of itself is a marker for predicting epilepsy. So yeah, if you were to throw that 55 number out, that time to first seizure after VTM connected would be much lower than 4.2 hours, but we'll get all that data on our final analysis. And then one thing that I'm going to do with our epileptologist is actually calculate the seizure burden in the first day of life. There's been studies done, I think it was Courtney Wustoff in UCSF, or no, excuse me, Stanford, who looked how seizure burden corresponds to a greater likelihood of developing epilepsy. And, if we validate that information, then, the onus is really on us to try to identify these patients with seizures sooner. So does that mean like remote monitoring of EEG? How do we get these patients hooked up faster? How do we get ASMs in faster? So yeah, generally speaking, I think the literature is pretty clear. The sooner you can capture seizures, the sooner you can treat, the better they're going to do neurodevelopmentally. And then of those patients that went on to develop epilepsy, it took us 2.6 ASMs on average to stop the epilepsy, and then 1.4, excuse me, stop the seizures. And it took us 1.4 ASMs to control seizures in the group that did not develop epilepsy. So obviously, the more anti-epileptics you're using, the less encouraging that is for whether or not the patient's going to develop epilepsy or not. So I wanted to just highlight those patients that went on to develop infantile spasms. And for the group here, you've probably never encountered infantile spasms in the NICU unless you had babies that were there for 5, 6, 7 months that went on to develop spasms. Maybe you have seen it, but in the three subjects, they were all HIE with or without therapeutic hypothermia. One of the MRIs was deep gray nuclei involvement with HIE. Another one was near continuous status epilepticus requiring 3 ASMs, and the other one was again, status epilepticus requiring 4 ASMs. And we found out that patient had a right MCA stroke. So I'm going to be working with our epileptologist, and I'll actually talk about this more, but creating a pathway for these high risk patients so that, we're not delaying treatment for patients who are inevitably going to develop spasms or epilepsy. Yeah, so we can talk about that just a little bit more. So yeah, I would say the whole goal of the project is to create a model to better forecast which neonates go on to develop epilepsy and who doesn't, and get them on the right pathway. So we've all seen patients in either two of these categories. I mean, there's the ones we were just talking about, the HIE with deep gray nuclei involvement, burst suppression seen on VTM, took 4 ASMs to stop the seizures. Okay, we can guarantee these patients are going to go on to develop epilepsy. So maybe that's a situation where I team up with our epileptologists who have done a fantastic job streamlining care for patients who develop infantile spasms. Maybe that's a situation where we have an EEG scheduled prior to leaving the hospital, a screening EEG, if you will, and maybe to be done every other month until they're a year old. Because again, the rate limiting step in treating these patients who go on to develop spasms or epilepsy is the detection of seizures. Oftentimes, families won't know for certain what they're seeing are seizures, and that's also another key point. Education, making sure that we are guiding families on what seizures look like as an outpatient and spasms so that they know to escalate to the emergency room if that's being seen. And then there's that other category where it's like, all right, you had low calcium transiently, you had a seizure, never require any phenobarbital. You probably never need to be seen by neurology ever again. You don't need repeat EEGs because your risk for developing epilepsy is extremely low. But then there's everybody else, and I think it's that everybody else that I'm hoping this research can help. Really trying to identify what is the seizure or epilepsy risk in everybody who's in between these two categories. And that way we can get them on the right pathway, either, not getting VTMs or getting VTMs or creating a new pathway that meets their needs. Because ultimately, again, the whole purpose of this is early detection of seizures so we can provide better treatment. Um, so with that, I'll field any questions. Again, this has been a ongoing research project that we're finally starting to input data over a decade. Um, and I'm hoping by year's end we can have something written up and published.
Thank you so much, Dr. Kayyal. Um, just out of curiosity, because I know you mentioned there was a difference in percentages between your study so far and the glass study. What was the N size for the glass study?
It was big.
Okay.
Did I not?
You
Yeah,
might have
so
said it and I probably missed it, but oh yeah.
let's see. It was 282. Yeah, and I just want to stress again, we should not be drawing any conclusions to any of what I've just presented. These are just glimpses into the data.
Mm-hmm.
But yeah, that glass study really was groundbreaking. I think whereas most people anecdotally would tell you, okay, yeah, we've gotten off of anti-seizure medicines in this group of patients that had HIE, we think they did okay. Well, this validates that.
Yeah.
So it was really ahead of their time. Like people who were early discontinuing anti-seizure medicines in the 2000 and teens were really ahead of their time.
Thank you.
I'm curious. I know you have like, and it's hard to control for, but there's a pretty high like loss to follow-up rate. And while it's difficult to go back retrospectively, I'm wondering if you're considering any type of like perspective data collection and follow-up for these kids to see if you could have almost like a secondary part with a lower loss to follow-up, because that might strengthen any results that you gain.
For sure. Prospective studies are always going to be superior to retrospective studies. In this particular case, I don't know. I don't know if there's an option for me to reach out to some of these families that we lost to follow up. If there is, it would make sense to take advantage of that. Um, but yeah, I think prospective studies in neonates is especially hard. I think they are, I mean, just like any other uh, research project, prospective randomized controlled trials are going to be superior. But yeah, we just have so much data. Yeah, if I had another project I was going to take on, I definitely wanna wanna make that a prospective study. for sure. But this one's probably just going to stay retrospective.
That makes sense. Thanks.
Great. Thank you so much, Dr. Kyle. Any other questions or comments? I know Beverly, you put in the chat that we have had a patient in the past with infantile spasms, so that's very interesting.
Yeah, do you remember him, Dr. Kayyal? He was a transfer, previously cold patient at a hospital in Ventura and then transferred here.
That
Parents were
va
super nice.
I vaguely remember like it being this giant thing with getting vigabatrin to the baby.
Yeah,
That's all I remember. I remember steroids were given, but then it was like, how do we get this baby vigabatrin? Should we be using ACTH in this critically unstable baby? So yeah, I
yeah,
remember. I wasn't too involved. Our epileptologist came in and saved the day.
Yeah,
yeah, that it was super sad case.
Yeah.
we had one a long time ago when like my first year as the neuro NICU director, so like 9, 10 years ago. It was lissencephaly, and the mom and dad wanted to do everything,
Mhm.
and baby stayed with us for a couple months and then developed into infantile spasm. So that's one I can remember too. So we've had a couple, but they're super rare and few and far between.
And very
Um,
sad.
Yeah, very, very sad. Yeah. Sam, I kind of want to go a little off topic and ask your opinions. I think a lot of nurses are asking, and I've gotten that question too. I know what my practices are about it, but what is your? I know we've talked about early cessation of antiepileptics. What is your thought about early discontinuation of EEG for cooling kids?
Well, there's literature to support its early discontinuation. Personally, I don't see unless I'm really missing something, I don't see the downside in continuing EEGs up until you're done with rewarming. And I'll say this, the families can hold babies with EEGs, right?
Yes.
Yeah. So I'll say this. Because we are on sedation, because we are on analgesics, it can make getting a quality neuro exam very hard. So to fall back on EEG monitoring throughout the recording is beneficial for me. So I've never seen the downside in it. Now, if we're talking about a resource limited institution and we have to start thinking about who are we going to take EEGs off of, there's some really good literature out there that can help guide that. And I'll just briefly say this. So one of those studies looked at a lot of neonates that had no seizures in the first 24 hours of life after cooling. And they either had normal or mildly discontinuous EEGs in those first 24 hours. The risk of them going on to developing seizures from that 48 to 72-hour period was very low. You combine that with a normal head ultrasound, the risk becomes zero. So it's not unreasonable for the milder cases that have normal first 24-hour EEGs in combination with a normal head ultrasound to early disconnect. You're never gonna find me asking for it, but if you wanted the literature to support that kind of move, it's there. And one of the things that, I'm going to be doing in this study too is, we're going to be looking at all those kids that eventually did have seizures. I'm going to be curious as to when did they first start having seizures? And I just from my prelim analysis, all of these kids that had seizures, it was in for the cooling patients, it happened in the first 24 hours of life. I do want to say one thing too. It's not impossible for us to classify a patient as HIE only to have them develop seizures for some other reason. So let me give you an example. So if you have a patient who's got neonatal encephalopathy, who's intubated, APGARs are 5, might say, okay, that's a patient that would warrant cooling. Um, what if the first 24 hours of EEG was normal? Does that mean they're for sure going to not have seizures in the next 24 hours? Well, not necessarily, because you don't know whether or not that patient truly had HIE. And so we actually have a kid right now that was going down the cooling pathway. And if we had taken off the EEG at 24 hours of life, we would have missed the many, many seizures that the patients went on to develop. And after getting the MRI, it doesn't look like an HIE at all. So I think case by case basis, I'd say if there's something strange in the history that makes you think something other than HIE, all the more reason to keep your EEG on for the full duration. And generally speaking, as long as there's no downside, I'm good keeping it on for 72 hours.
I
That's the long of it. There wasn't
I
the
kind
short
of
of it.
I echo you too. I agree that the pretest probability, if it's there for milds and milds with normal for milds with normal head ultrasounds, it's very strong to take it off. But I agree, the fact that we can hold babies while they're on EEG, um the fact that we usually don't get sores or any kind of pressure marks at only 72 hours. Um, I stay conservative. I do keep our kids on EEG regardless of their staging. And I was the primary on that one kid you're talking about too. And there have been times, multiple times, where we thought a baby, because of the nature of the delivery, was HIE, and it ends up being something else, whether it's a stroke or even something metabolic. So I do tend to keep them on. You won't, same as you won't be seeing me asking our techs or our neurologist to take off a EEG before 72 hours.
Yeah, it's just one extra layer of neuro monitoring.
Agree.
Okay, well, if anyone's interested in helping out with this research that I'm doing, it's a big team effort. It's not just me. It's a lot of our epileptologists. It's getting resident support. We've had some research assistants help with the input of the data. The research coordinators from the NICU and Dan that really helped with Terry build the HIE database. Yeah, but between the two databases, there's so much we can publish. This is one question of 1,000 questions we can answer with all of the data that we're obtaining on these neonates. So if anyone is interested or has an interesting question that they want answered, send them my way, or if it's better suited for Terry, send it to Terry.
Thank you, Dr. Kayyal. I forgot to mention at the top of this meeting, but one of the goals for NICU nursing this year is to kind of revamp our bedside nursing core group. So Great Team is one of those. And I think this is a good avenue to recruit some of those nurses to become more involved in QI and research. So thank you.
Sure. Okay.
Great.
No one has any other questions. I'm going to head back down to clinic. Thank you.
Thank you. Thank you so much, Dr. Kayyal, and thank you everyone who was able to join today. There's a little QR code there. And our next Neuro News is February 18th with Dr. Morris, our NICU psychologist, to kind of just give a little bit more information as to what her role is and what it is ever evolving to be. So if you're able to attend or want CEU credit, please sign up on Cornerstone, and I will see you on the unit. Thank you again, Dr. Kyle.
Oh, yeah. Thanks.